Hello, welcome everyone. Welcome. Uh, I'm so excited to have another VMR with you today and sharing the discussion space with Johann, who's been with our VMR for I think a few months and really uh, has shown so much dedication, and I've learned so much from you, Johann. Also, thank you for Dan for doing teaching points as well as Amal for doing scribing, and I think it's your efforts who make this session possible today. But also equally excited for Sherry returning to present yet another case. I remember last time discussing your case, and I wouldn't uh, give too much detail, but it was a lot of learning and reflection, and also remembering your dedication to your patient care. So I can't wait for another case to discuss to learn from you. I think with that, I'll maybe pass the mic to Johan and to say hi as well as Dan and Amal, and then we'll finally let Cherie introduce herself and present the case.
All right. Hi, everyone. I'm Johann. I'm a proud TP Solver Academy member and a proud IMG from Cameroon. I'm currently based in Barcelona. It's 1 a.m. here, so I'm sorry for my face. Super happy to discuss this case with Mengyu. She's been a real mentor for me in this academy, and I can't wait to start discussing this case with her. Thank you.
Yeah. Dan, Amal, do you want to say hi?
Hi everyone, my name is Amal. So I went to the same residency program as Sherry. So hi Sherry. And yeah, I've been a CP Solvers member for a month. So happy to be here for more like few months now.
That's wonderful.
Hey everybody, I'm Dan. I'm super excited to be here. I love these sessions. I love being involved in them, especially the teaching role, because there's just so many pearls we learn from each other. So just so excited to be here with you all. So excited for this discussion. Can't wait to get started.
Yeah. And you're all from Atlanta, right? Like we have like Atlanta crew here today. Wonderful. Hi, Cherie.
Hey, so hi everyone. My name is Dr. Sherry Walls. I was actually introduced to clinical problem solvers by Amal about the cases. So she told me about her first case and she was like, you should do it. And I was like, okay. And then so since then I've done a couple of cases because of Amal. She had such good things to say about it, and our attendings have used clinical problem solvers like diagnosis schemas of like hyponatremia and stuff like that. So I knew about it, but I didn't know that there was like cases until actually Amal told me about it. And then Amal and I met during residency. So yeah.
How's life as a hospitalist?
Oh, the attending life is so much better than residency.
That's very encouraging to hear for all
Yes,
ones
it's
since
so much better. I'm loving it. I'm actually gonna be going to work after this. So yeah, I mean it's definitely, I mean, residency is hard, but it's definitely worth it at the end because I mean especially for our residency. They were pretty hard on us. I'm pretty sure every residency is hard, but they were pretty hard on us and made sure that different scenarios that you'll be put in that you'll be prepared for, and I wouldn't feel more prepared. So yeah, I'm very thankful but also grateful that I'm no longer
Yeah, that's wonderful. So Amal, I think if you can share the screen, then we can get the case started. Wonderful. Sherry, we can't wait for your case.
Nice. Did I go ahead and get started or wait?
I think yeah, you can get started.
Okay. All right, everyone. So let's go ahead and get started. So the chief complaint is sudden right-sided weakness with slurred speech. Okay, so let's go ahead and start with the HPI. So we have a 55-year-old female with past medical history of hypertension that came in by her son that said that she had sudden onset right side weakness and slurred speech. She didn't have any other symptoms, no seizures, no additional confusion or anything of that nature, no fever, no chills, no chest pain, no shortness of breath, belly pain, nausea, vomiting, changes in urination or changes in bowel movements, just onset of right side weakness, dizziness, and slurred speech. And this started a day prior.
Yeah, wonderful. Shall we pause here, Sherry?
Mhm.
Awesome. Johann, do you want to tackle the first aliquot?
Of course. Wow, what an amazing start. So, I mean, I love the presentation, and I would say when I see a patient coming for stroke-like symptoms, first I look at the time frame. It's sudden, it's quick, and I try to first also think about stroke mimickers. So, for example, hypoglycemia or any condition that can mimic stroke and rule it out. And overall, the presentation of this patient, especially with the with hypertension and what we have from now, the right-sided weakness and slurred speech, my first impression will be stroke or a stroke mimicker. So I'll stop there, and I mean, at first, that's what I'm thinking about.
Yeah, I love your start, Johan. It's I think so important to consider the stroke mimicker, as you said. I think I've had experience where someone who has so much stroke risk factors, and then developed like localized symptoms and caught a cold stroke and did all the workup in the end found to have hypoglycemia. So I think so in most hospital it's now part of the stroke like protocol where you have to check a glucose before you even call a stroke. I mean, you would call a stroke, but the first step would be checking a glucose. Yeah, and I think along the line is like we're thinking about hyperacute neurological symptoms. Like we have to first, as you said, prioritize vascular and primarily stroke here, whether it's depending on whether what kind of stroke, regardless what kind of stroke, but vascular, but also like consider seizures and migraine being on the differential. Although from the most recent case, I also learned that panic attack should be on the differential in certain population, or if the presentation is like dramatic. But here, I think getting started on the stroke workup is really the first step. So what you would do is, yeah, you would like call stroke code in the ED and get the patient to a CT scan, usually a CT non-contrast and CT A head and neck. And then from there, to kind of tease out, making if there's no bleeding in the brain, then you start with aspirin. But I think I'll pause here and hear more and get more information from Sherry.
Yes, so that's also very good. Just to add to the differential, usually, I mean, this patient is 55, but sometimes I see a lot of patients that come in and they have altered mental status and slurred speech, and they just have a UTI infection. I know that I said that the ROS was negative, but sometimes when patients are older, like greater than age 65, they have very like non-specific symptoms. You do the stroke workup, of course, but they also have a UTI. And all these symptoms, once you start giving them fluids, once you give them antibiotics, then they're fine. You follow with the MRI, nothing's there. Like, oh, this patient just had a UTI. So something also to think about when a patient comes in with altered mental status, maybe not right-sided weakness, but altered mental status, also think about underlying infection as well. So with the past medical history, the only past medical history that this patient had was hypertension. The medications that she was on was amlodipine, 10 milligrams daily. And she had hyperlipidemia, but she was on Lipitor 80 and indapamide 2.5 and losartan 100 milligrams BID. So as far as family history, social history, allergies, and health-related behaviors, there were pretty negative, really non-specific to all of those that didn't really contribute to the story. And she didn't really have that much to add in this case, and nor did the son. So basically at this point, we're kind of we're not that much limited, but we're kind of either stuck with vascular issue, like you said, or a neurological issue or some type of underlying infection, which is less likely on the differentials. So let's go into the vital signs. So the vital signs, blood pressure is 202/100. Heart rate is 98. Temperature is 98. Respiratory rate is 16, and oxygen saturation is 100% on room air. So for the physical exam, so let's start with everyone is thinking about stroke. So let's start with neural. So she was only alert and oriented to herself, but not to time or her son, the place. She did not have really much short-term or long-term memory, just really to herself. She was oriented. Her language, she was fluent and spontaneous, just confused. There was not any, when the time I saw her, she didn't have any like dysarthric appearance or speech at that time. As far as when you're looking into concerns of a stroke, you basically have to do a full neuro exam, which I know people love to do because it takes so long. So I did cranial nerve testing all the way throughout. Her cranial nerve 2, 3, 4, 6, 5, 8, 7, 10, 11, 12. All of that was within normal limits. As far as her motor exam, her upper and lower extremities were 5 out of 5. And her as far as all her flexion, hip flexion, all that was within normal limits. As far as her DTRs, her deep tendon reflexes, they were 2+ in the upper and lower extremities, and her plantar response was down going bilaterally. Her cerebellar exam, so she had bilateral upper extremity tremors that were noted, and according to the son, that wasn't new. But she did have finger to nose without dysmetria and bilaterally, and her sensation was intact. So overall, the only thing that was really pertinent for her was her elevated blood pressure, and she had a fairly unremarkable exam from other than she was only alert and oriented ×1.
Yeah, that is interesting. So we have someone who, even though the history was reported as a stroke, but actually doesn't have a focal neurological deficit, it seems like, just like there's some tremors in the bilateral upper extremities, right? And the blood pressure is pretty high, which at first you would think about stroke, but I think with a new exam, we have to pivot our differential. Yeah, Johan, I'm curious to see what kind of thoughts came to your mind with this new data.
I mean, it was unexpected, and that's really interesting that, after having that sort of HPI, now the physical exam, it's almost normal, a part of the high blood pressure, which we can call now, for now, hypertensive urgency, I would say, I mean, since we have no sign of end organ damage. And I would say it can still be a TIA, right? So the patient had focal neurological deficit, and now it has resolved. So something happened, but we don't know exactly why, what. So, well, for now, I would stay cautious and I would think first about the blood pressure, but overall, it didn't rule out in like a previous neurologic event that happened to this patient, but the physical exam is definitely surprising. What do you think, Mengyu?
Yeah, I'm thinking along the same line with you, because I think we have to dig more into the history. Did he actually have a right-sided weakness and slurred speech? Because those would be compatible with a stroke. I forgot to like kind of discuss about localization. Like would be compatible with a stroke on the left side of the brain potentially. Either in the like the hypothalamus area or like in brainstem potentially. But now that so I think really clarifying if because if he did have some neural deficits, he could have a TIA, as you said, and maybe it's like resolving because TIA is basically defined by like resolving within an hour, but often like minutes. And especially with the high blood pressure, you think about a stroke, which is expected in stroke because of the need for more blood perfusion to the brain. But now if we think what else could it be other than stroke? But the patient and with the high blood pressure, like thinking along the line of hypertensive emergency, I think we have another case recently about like what would encompass a emergency with the bark mnemonic that was shared, brain, aorta, like aorta, and retina, heart, and kidney and heart. So we don't have much data yet to support that, but I think hypertensive emergency with some other things in the brain should be considered. I guess I'm not quite sure the bilateral upper extremity tremors, if that's something, if it's unilateral, I think I will still lean towards a stroke. If it's bilateral, I think it's very important to clarify the timeline for that. And I think the tremors has its own differential. I'm curious, Johan, if you have any thoughts on the let's say if it's a new tremors, what make you think of when it comes to tremors? And we don't know if it's a noise here or it's actually a true suggestive symptom.
Well, when it comes to tremor, I think we have two big buckets. Is it tremor at rest or tremor when he's active? I think when the patient is active or stressed, it's essential tremor or physiological tremor due to stress. And at rest, it's more linked to Parkinson or maybe heavy brain damage over time than something really acute that will just present with bilateral upper extremity tremor. But the patient is 55, he has hypertension, maybe he has a history of alcohol abuse. I mean, there's so many things that the patient wouldn't necessarily say right away. So I'm not really, for now, concerned about the tremor as it might be essential tremor, which is not, well, that concerning overall.
Yeah. How about I should maybe have brought up earlier. It's like I think Sherry was also telling us the patient has altered mental status and is like proved on exam now is only and oriented to self. By the way, if someone is not oriented to self, that I learned that usually suggests a psychiatric problem. But this patient is at least oriented to self, but definitely has some encephalopathy going on. Johan, do you want to share more thoughts around that or?
All right. So my framework regarding altered mental status, especially acute altered mental status, would be the mnemonic MIST. So metabolic, infectious, structural, and toxin. So with this patient, we can definitely have the S, which is structural, since the patient might have maybe he had a stroke. So it definitely entering the structural category. So we can definitely explain the altered mental status. Now, on the exam, apparently the patient was responsive on the exam, so I don't know if we can still categorize it as altered mental status. But regarding that, I frame it with the mnemonic mist.
Yeah, thank you, Johan. I definitely think along the same line as you do. I think for both in acute encephalopathy and tremors, actually, I think the approach is very similar. It's like an N mist. I think for tremors, we have the N because like we have like the common Parkinson and essential tremor being like the most common causes. But otherwise, you think along the line of the mist framework. So I think I would besides from getting brain imaging to assess for potential stroke or TIA, I would also getting all the metabolic workup. And if you look at this MIST framework, there's like a lot of labs you can send in the moment to rule out the metabolic cause, like liver, kidney disease. I could imagine like those can cause tremors, maybe usually not in the hyperacute way, but a lot of other electrolytes and then I would scrutinize the medication. I think we have the list of medication and that is not really contributing here. So, but I would ask about potential other exposures to meds and toxins. And I think, and then infection, we're not seeing any clue here, but I think the labs will be helpful and additional history if there's any sign of that. And then really beyond the MIST framework, and by the way, under metabolic, there's like additional things that you have to kind of circle back to consider, like urinary retention or bowel retention are the things that are common fly under your radar. So I usually do it as part of my initial screen anyway, just to get it out of the way if that's not the cause. But I think really beyond MIST, then we have to think about EEG, MRI to assess for those other mostly neurological conditions, including seizures and intracranial inflammatory process and some psych issues like catatonia. But I think we have a pretty good differential discussion here. Maybe we can talk about the management based on our initial workup. So I guess I'll pass the mic back to Sherry to tell us more.
So with this, I'll tell you now that those labs did not help you whatsoever. All those CBC, CMP, UDS, ETOH, thyroid function, EKG, chest X-ray, everything normal. So then that goes back into, okay, as one of our colleagues have stated, it kind of takes out of the metabolic, the infectious, and the toxins, but it does not take out the structural. Even though that this patient doesn't have any really neurological changes other than alert and oriented ×1, I mean, she has upper extremity tremors, but speaking with the sun, that's not really new. So that's not something that I'm kind of hanging my hat on as far as regards to helping me with the situation. So my next thing is I have to rule out structural abnormalities, which is going to start with imaging. So as we know, the brain is money and so is time. So in this case, this patient is out of the window for any TPA or anything of that nature because their symptoms started basically 24 hours ago. The reason why I'm pointing towards that is because when we have a patient that has altered mental status and we're concerned for a stroke, we try to get them to be evaluated by either how your hospital is, it's depending on how your hospital is set up. At our hospital, we have teleneurology that evaluates the patient to see if they're a candidate for TPA, which is a thrombolytic agent, which you can give within like a 4-hour window if they don't have any contraindications. Please don't ask me all the contraindications, but because there's 5 million contraindications to TPA. But in this case, this patient would not be a candidate for TPA because our blood pressure is too high. And anyway, but so let's go ahead and start with the CT head without contrast. So the CT head without contrast was negative. The CT head without contrast, it helps us to see if this patient is evaluated for basically a bleeding, but it doesn't necessarily rule out if there's stroke or any other abnormality structurally. So I think someone else said something about dissection. So we got a CTA, head and neck, and chest. All of that was negative. But it still does not help us rule out for the MRI. So the MRI brain shows edema primarily in the left occipital lobe concerning forward press. I think I saw someone say that in the chat. So that was really good as far as a differential, because sometimes, because it is a rare disorder, sometimes we forget to think about that because it typically occurs in patients that are like middle age. It's very acute. They have severe hypertension, which this patient has. She's 55. She's 3 antihypertensive medications. Her blood pressure when she came in is 220/100. Of course, we have to rule out other things, as our colleague has said, with MIS, with metabolic and infectious and toxins, but we also have to rule out structural. And sometimes with press, they could have a headache, they could have a migraine, they could have altered mental status. In this case, this patient only had altered mental status and she was only alert and oriented ×1. Come to find out, all those medications that she was on, she was not adherent to. So that also increased her risk for press. So during the hospitalization, I was able to get specialist support, and they were able to also reconfirm based off looking at the imaging that the patient had PRESS syndrome. They also did an EEG, which basically showed in the left hemisphere that there is slowing in cortical irritability, and that these findings are secondary to PRESS. So they recommended patient to be on Keppra and repeat MRI in 4 to 8 weeks. And because the adverse effects of PRESS is seizures, you have to also, based off the Georgia law, you still have to tell them don't drive. You have to be seizure free for 6 months. So yeah, that's the case.
Oh, wow. I think first you highlight a really important lesson here, which I think actually Dan commented in the chat, is like when you have someone with hypertension and altered mental status, other than I think I had thought about it, crossed my mind about like how like an intracranial process causes hypertension and encephalopathy, being one is the structural cause we're thinking about. One is the strategic stroke. I think that's actually on the framework for altered mental status if you look at it. So one is a strategic stroke in a location that, because stroke doesn't normally cause encephalopathy, just cause like more localized weakness, doesn't cause encephalopathy alone. But if it's in a specific location, like in certain thalamus area or brainstem area, you could have augmentation. I think what's curious, what's kind of odd about this case is that the patient's focal deficit seems to be resolved. But I think then if you look at that schema for altered mental status, another differential is actually PRESS. So I think that's such a great thought, and actually really fits the picture here. However, yeah, Johan, maybe I'll pass the mic to you to kind of share what you know about PRESS, and see if we can get more juice from this case about like PRESS and related conditions.
Wow, what an amazing case. Thank you, Sherry, for sharing that case with us, but not just that, and I mean, giving us all the teaching points through the case. It was an amazing journey. Regarding PRESS, I don't know a lot about PRESS, but I think it means just a syndrome where you have encephalopathy, hypertension, seizures, and other neurologic conditions that are reversible, and basically linked to high blood pressure. So the goal is really to control the blood pressure and give anti-epileptic in case of seizures. But the thing with this syndrome is that it's reversible, as the name says, posterior reversible encephalopathy. So yeah, I've never seen it in my really young career, and I'm really happy to be discussing this case today. Really interesting case.
Yeah, thank you. Maybe Sherry, you have some prepared more teaching for us about around PRESS. I'm not sure, but like what I have for PRESS is I think it's really featured by acute blood pressure elevation or certain drugs like chemo or immunosuppressant that leads to cerebral, dysregulation or the endothelial dysfunction, which led to the edema, in the occipital and sometimes adjacent parietal lobes. I think classically you would expect to see some headaches. I'm not sure if this patient headache, but like encephalopathy, seizures, or visual disturbance, which I could imagine if the patient is too altered that we may not be able to get that complaint, from the patient in terms of visual disturbance. Most commonly, I think like, we hear about this case in like patients with pregnant patients with preeclampsia or eclampsia kind of background. I've seen once is a young lady who had a kidney transplant who's on tacrolimus, and she presented with a seizure episode, and that's when it was like a classic case for PRESS in that setting, like a solid transplant recipient. Otherwise, you can see it in patients with ESRD or lupus, which is but on the really rare side. I also like recently learned about PRESS from it's like related to the RCVS, also called reversible posterior cerebral syndrome or something. Yeah. And for that, you would have more like I think it's like one of the differential for thunderclap headache. So I was initially wondering like if the patient would have headache, and that would lead me think about that. Yeah, I'm trying to think. Sherry, did the patient have any headache when that was reported in history?
No, she did not. The only thing that she had was basically the slurred speech and right-sided weakness.
Got it.
Yeah, that was really it. The interesting thing about this, the only reason why I thought about press is because we actually had one during residency, and that's how I learned about it. And this patient, and so that's how I end up thinking about it, because you don't really hear about press that much. And so based off like the information that I had learned during that time is that, press is posterior reversible encephalopathy syndrome. Basically, as you stated, there are a lot of people that it's a rare disease, but there are people that are at risk of it, such as you said, like SLE, people that have gotten transplants and uncontrolled blood pressure. But the clinical features are so different. Like the only thing that really, there's like maybe like 50% of patients that have like vision changes. There's like 20 to 39% of patients that have issues with visual acuity, but based off, I believe it was the New England Journal of Medicine that I read a while ago, that was saying that 94% of patients have nonspecific encephalopathy. So if you're thinking of a patient that is coming in with a stroke and they're not really having any deficits, but their blood pressure is high, you should also think about press. And the way that you can rule out press is doing the MRI. If you have very high clinical suspicion, maybe you can speak to your radiology team and the tech that's there to possibly do the MRI stat if it's available. But a lot of the time, sometimes the CT won't show any focal vasoconstriction or vasal edema near the areas of the posterior occipital aspect. So it's something to think about. As you stated, like in different differentials. Of course, there's other things that mimic it, like hypoglycemia. Press also can mimic patients that are pregnant, eclampsia as well. Demyelinating diseases, as well as vasoconstriction syndrome and toxic encephalopathies as well. But in this case, this patient really only had altered mental status and high blood pressure. So I know press is rare, but it's not that rare. This is my third time picking up a patient with press. One in residency and two as an attending. So thought it was
Wow.
good to share.
Yeah, Sherry, I'm curious, how did you end up managing this patient?
So I manage with the specialty support with neurology. So with this patient, because of the altered mental status, they weren't 100% sure if she had a seizure or if she did not have a seizure. Because of increased risk of seizures, they went ahead and got an EEG, which did show abnormality where the MRI was done. So because of the increased risk of epilepsy, they went ahead and started her on Keppra. And then they had a follow-up with the MRI in about 4 to 6 weeks.
Got it. I forgot, did you mention like in the acute setting, how did you like manage the blood pressure and all that?
So with the blood pressure, so of course, so blood pressure is, you have to figure out what's the underlying cause for the blood pressure, right? So if this patient has a stroke or she has something going on with the brain, anything of that nature, you can do permissive hypertension. She already was not a candidate for TPA because she was out of the window for that. So initially, we were like, oh, she's all on all these blood pressure medications. And then eventually came out the fact that she was not adhering to those medications. So we allowed permissive hypertension for the initial day. And then we started to restart her on her home medications. She actually did not need 3 antihypertensive medications. It was just the fact that she was not taking them. So she ended up being on losartan and hydrochlorothiazide, which she tolerated fine, and then she was on the atorvastatin with Lipitor.
Got it. Yeah, I also rate that, like, PrES usually have a good prognosis if you manage it appropriately. So basically control the hypertension, like not to, I read like not to exceed like more than 25% in the first hour, but then normalization over the next 24 to 48 hours. You can use IV drips to kind of bridge until like you achieve more, steady blood pressure improvement.
Right.
Yeah. Um, I think just to reflect on the case also, I think Ethan asked, which I was also curious, like the initial slurred speech and like the transient slurred speech and right-sided weakness, do you think it's part of the press? Or how did that kind of, be transient? How do you explain that? Is that, I don't know if it's a common, I have to kind of think more whether it's like a one way
So
stress can present.
yeah, so when I saw her, she didn't have the right-sided weakness, as you can tell by my physical exam. She didn't have the right-sided weakness and she didn't have the slurred speech. She was only alert and oriented ×1. That was told by the son that was there with her. That's how she presented the day before. So I'm not 100% sure if that was transient or did it resolve or did it actually happen. That was just something that was reported by the son because he's the one that brought her in. But when I saw her, she was only alert and oriented ×1. She ensured strength and everything was within normal limits. So I think it's kind of like the nuance.
Yeah. Yeah. And I also like try to see what I've read in the past. I think like for the symptoms, first, really wanted to highlight what Mark mentioned in the chat that 25% of the patients actually are normal tensive, which is impressive because we don't usually associate that. We don't think about that if we see a norm. So I think it's very helpful to know if you, you know, uh, like a normal blood pressure doesn't rule it out. But I think like symptom-wise, patient usually sometimes have headaches that are usually dull headache instead of like a thunder, but there's occasional like thunderclap type of headache, seizure like in the majority of patients, and even like 18% will have status epilepticus, and then 20 to 40% patients could have visual abnormalities, which we don't see it here, so that but only less than half of patients have that anyway. And then less common findings are like focal deficits, like including like focal paresis or incoordination or things like that. I guess it's maybe an unusual presentation of this press. I think still crucial to, I think we got the imaging and make sure it's not a stroke, but so I assume that's like maybe an unusual presentation of this press here. And then a minority of patients also have like coma or widespread edema and even herniation, which is like a really bad scenario. Johan, I want to see if you have any other reflections from this short and sweet case.
No reflection. I think what's striking to me is that actually when Sherry saw the patient, apart of the high blood pressure, there were no other symptoms, which is interesting since press is supposed to manifest with other things. And well, I also want to maybe know how bad was the MRI and how do you quantify the edema in press? So when do you know it's maybe a really complicated press over a simple episode? So how will the edema will show on MRI, for example?
So I'm
Oh,
sorry.
go ahead. Jerry, go ahead.
So the MRI, so when you look at the MRI, you're gonna see just like as with her, you'll see the edema in the left occipital lobe, that's specifically in that area. So that's how you can tell that it's pressed. I'm not sure about the specifics on regards to the severity or not, But basically, because it's in the name, as you stated earlier, it's reversible. So that's why they repeated in like 4 to 6 weeks. In her case, when she followed up, when they repeated in 4 to 6 weeks, it was gone. So, yes. So the main point is really when you have a patient that has altered mental status, because that's like 90% of cases that have PRES, they have encephalopathy. And they don't necessarily have any neurological deficits. You also want to think about PRES in addition to your MIS, even though it's a rare cause, but it's something also to think about as far as part of your differential. Because the good thing about it is reversible. So once you find the underlying cause, I mean, people have a good recovery, they don't have any additional focal deficits, and they can go on about their lives. So it's something to definitely think about and also help with the mortality of these patients as well. This patient went to the ICU, of course, because you have to do neuro checks like every 2 hours to ensure that there's nothing else going on. You have to have them seen by neurology, which all this patient did. She was started on hypertensive medication, followed up in 4 to 6 weeks, got the MRI. She was started on Keppra, and then subsequently her symptoms resolved, her blood pressure was controlled.
Yeah, thank you. Yeah, I think for the neuroimaging, it's really like bilateral posterior circulation, edema, and white matter changes. And you can sometimes even see that on a non-contrast CT. I think here we only see it on the MRI. And the flare of the sequence and T2 are the most sensitive to the vasogenic edema, so that you can see those hyper intensities on the flare MRI. And that's like the most typical location, but there could be other patterns, as mentioned earlier. But yeah, I think it's a very interesting case to see, like in someone with no risk factors that we commonly associate that with PRES, but actually has a PRES findings on the imaging. But I think eventually the management is, I guess, similar to hypertensive emergency, hypertensive encephalopathy, and you just and knowing the prognosis and repeat imaging. I think I remember there's another case where also repeating imaging in 4 to 6 weeks of like the ultimate management too. Yeah. Anything else, Sherry?
No, that's all.
Okay. Yeah. Thank you for sharing the case with us. I think with that, I'll pass the mic to Dan to share with us the teaching points. I think, Dan, you're the one who actually called out this diagnosis, so kudos to you, and can't wait to hear your wisdom and reflections about the case.
No, I mean, this was such an incredible discussion. I mean, I love the way you guys started off just triaging the issues and then kind of broke down frameworks to approach each issue. I think that was incredible. So I'm just going to kind of walk through kind of the main things that I took away. And I'd love to hear your reflections as we wrap up. So I think the first part of this was hearing the sudden onset right-sided weakness, dizziness, slurred speech. The first thing that comes to mind is there a potential CVA? And so something that we brought up that was critical is assessing the time frame. When was the last known normal? What did the patient look like? What are specific details in the history that point to certain neurologic deficits and how these may have changed over time? The second thing that we want to consider is what are mimickers of strokes and how can we quickly assess those so we're triaging effectively. And so some things that we talked about are hypoglycemia, infection, seizures, migraines, intracerebral hemorrhage, things that are kind of working on in the background as we kind of set up to assess the potential stroke. And finally, for our CVA workup, imaging is really kind of our mainstay. And so 3 things that we use are the non-contrast CT head with perfusion, and of course, per institution, a CTA head and neck, just to assess for the arteries. So next, moving into frameworks. So the first framework we talked about is altered mental status. And this is just a classic. I love it every time I hear it. It's just a tried and true MIST. So metabolic, infectious, structural, toxins. But we also got a little bit deeper. We learned that it's important to consider urinary and bowel retention as potential causes, contributors to this. We also thought about expanding beyond MIS to include EEGs and MRIs. And of course, like, spoiler alert, always considering press in the background as well. We also had a great look into frameworks for tremors. The first question to ask is, can we see it at rest? Can we see it when the patient is active? When is it really presenting itself? And then we got a great mnemonic for tremors. It's missed with an N added to it, and the N reflects neurodegenerative changes, such as what we see in Parkinsonian tremors or cerebellar degeneration. Great mnemonic. And then finally, we kind of move into press itself. And so kind of like what we talked about, press is basically a setting of endothelial dysfunction, has multiple different triggers, often high blood pressure, sometimes infectious causes, but really we're seeing signs of vasogenic edema. And I think one of the really key points that Sherry brought up is you may not always see this on a CT. That can be less sensitive. And so really considering an MRI brain to evaluate that can be so helpful. Patients, their presentations can be very, very varied. Some present with migraines and headaches and visual disturbances, but like Mark mentioned, 25% of patients can be normotensive, and these presentations can be super variable. So always important to keep this in the back of our heads. Something that we also talked about is RCVS can often share triggers with press, but one of the things that really differentiates it is the presence of that thunderclap headache. So just something else to keep in the back of our heads. And finally, in terms of management for press, we're thinking about seizure control with AEDs, and finally, blood pressure control outpatients, so we're minimizing recurrence. And as Sherry brought up, press is reversible. So hopefully getting a repeat MRI in 4 to 6 weeks, we should see improvement in that vasogenic edema. So just incredible discussions, great learning points for all of us. Thank you guys so much. I really appreciate it.
Oh my God, Dan, that's such an epic teaching. I'm so impressed, and like I also love how you highlighted like knowing the timeline, the last non-normal, and everything. Like you said it you taught us so clearly. Thank you so much, Dan, and thank you so much, Amol, as well for keeping the whiteboard and describing the case. And again, it's such a pleasure co-discussing with you, Johan, and thank you, Cherie, for bringing us this sweet case and teaching us about press. Thank you so much. I hope you all have an amazing day. Thank you everyone for joining and chiming in the chat.
Bye.
Bye.